We'll try and cover the examination of a adolescent and young adult hip. So as you know, this is not going to be same like what you would see in the younger children, like when you see DDH and things like that in younger children. Examination is a little bit difficult and is different. Young adult is completely a different scenario because the type of conditions that you will see some of the younger ones, but there is a complete different gamut of conditions that get added on in this age group. So, when people or adolescents and young adults come to you with hip pain, there can be a multiple or a multitude of cause, and it's our job to find the cause and then, depending on them, give them an option of what we call as hip preservation. So these causes can be extra-articular, can be intra-articular. It can be because of the muscles, because of the nerves, and because of so many structures which are around the hip. Anything can cause hip pain. So we need to be very, very careful, examine these individuals very carefully, and then using your clinical acumen and then radiological imaging, come to the right diagnosis so that we can plan the adequate treatment for these individuals. So, in hip preservation, this is now what we talk about. It's called the layer concept. Every time we think about in this layer concept. So, what we divide the area around the hip joint into five layers. And when we start examining and start thinking of treatment, we have to start thinking at each of these layers and uh, then plan your treatment. So the first layer is the osteochondral, that is your bone. The second layer are your inert stabilizers, that is your capsule and ligaments. The third layer are the muscles around the hip joint. The fourth layer are the neurovascular structures, the nerves and the vessels. And the fifth layer is the kinematic chain. So the kinematic chain is basically the hip joint and its association with the pelvis and the lower back, and how they work together, which can also be a pain generator. So when we start thinking about hip preservation and examining, this layer concept should be there in your mind. And once you have this layer concept, this is just a small overview, and these are the multitude of conditions that you can find in each layer. And each of these layers are interconnected. Like, just we'll take into example over here. A patient you may think has just FAI, but with FAI in the second layer, they have a labral tear. Because of the constant labral tear, they can have flexor and adductor strain or tendinitis, and long standing that can also cause back pain. So if you start thinking of these conditions and start examining as a layer, then you can get an entire layer diagnosis and then properly plan. Because if at all in any of these you do not look at the rest of the layers, you can treat the bone as well as you want, and the rest of the conditions, if they go unnoticed, they will not get the right treatment and the right result that you would aim. So this is the first thing that you need to start about thinking whenever you're examining these children. I would say individuals more than children. And then based on the layers, you can see there's a multitude of things that we can start thinking of in our mind based on our examination. So, with any examination, as we know, clinical history is extremely important. A detailed medical and family history. We know that conditions which have FAI can run in the families. 2.3 times they have a higher risk in siblings. So always look for family history. Always look for your basic previous surgeries, other hip problems, activity related problems, the type of symptoms, the onset, duration, and what are the provocating factors, and ligamentous laxity. So this is a simple chart which I used to use when I was doing my hip preservation fellowship, and I still use it in my clinic just to give me an overview of what questions that I need to discuss with the patients to take it down. So this basically covers all the things in your history that you would need to ask a patient if they are presenting to you with hip pain. So you need to know about the onset, the type of pain, if any injury, then if there are any popping, locking, or clicking symptoms, knee pain, back pain, any other diagnosis, any previous treatments taken. Uh, Also, you need to know what limitations does the child have. It's not just hip pain. It is when does the pain come? Is it in standing? Is it in walking, sitting, or just getting off a chair, or getting up from the car seat, doing sports, stairs, walk? So you should go into detail. A lot of people will just look at the X-ray and say, oh, FAI is there, or the child is completely asymptomatic, but X-ray showing so and so. But if you really go into detail, there is always some symptom which is there. Then it is our job to really see the significance of that symptom, and then do we really need to treat it. So, coming to the hip examination, just this supine examination does not stand, especially in these older individuals, especially when we will be talking about certain conditions. You need to examine in all of these positions, your standing, supine, sitting, lateral, and prone. So make sure to check the hip and do the test in all of these positions. So by and large, in any hip examination, these are the things that we want to see. You want to see the stance, how the gait, your inspection, your palpation, localizing your pain, the range of motion, uh, any impingement or special test. You want to see the neurovascular, so that is your power. You want to see the version, and there are certain special tests. So this by and large covers all the layers that we spoke about before. So, stance, basically, you will see the child first in standing. You will see the positions of the anterior superior iliac spine, posterior superior iliac spine, the position of the knee. The If any leg discrepancy can be seen, you'd always check them on a single leg stance to see the Trendelenburg sign. Look at the mechanical axis. Always look at the gait. There are lot of conditions that we can pick up just with the gait, especially if they have a short limb gait or an abductor lurch or torsional abnormalities. Looking at the patella position. Inspection, you look at the lie of the patient. You look at what position they like keeping their hip at ease if they are specifically in pain. Now the thing with hip pain can present in various positions. It is not just always in the groin. If you see this, Cloesi in 2009 gave this nice chart that hip pain can present in various ways. 88% can present as just groin pain. It can just present as anterior thigh pain, knee pain, trochanteric pain, lateral thigh pain. It can also present as just low back pain or buttock pain or posterior thigh pain. So any these kind of pains, be wary about hip pathology and lower back pathology. Look at any previous scars or signs of previous surgeries. Always palpate every bony prominence starting from the anterior superior iliac spine, your iliac crest, your greater trochanters, ischial tuberosities, your groin, anterior joint line, and the posterior joint line. And again, do recheck these in sitting position as well as cross sitting position if the individual is having pain. Localizing these kind of pains can give us certain ideas of what kind of condition that might be. So usually your FAI and retroversion type situations do give you like an inguinal pain, and the patients usually complain of pain in the inguinal region, and they will usually put their hand uh, on the inguinal area, and that's called the C sign. So if the pain is more in the gluteal region or in the other region, it can be even because of excessive antiversions. So this is a small, uh, these are not panacea, but you can start thinking if you look at that. So any piercing pain in movement usually can be because of labral situations or adhesions, loose bodies. Constant pain is usually inflammatory. In motion, it is FAI, but constant pain and night pain is usually a precursor to arthritic pain. Burning type of pain can be in inflammatory conditions or starting of infections. Rest pain, startup pain, and pain during continuous motion is usually arthritic pain. This is the type of pain which we would not want to see, because usually when this type of pain is there, this hip is beyond usually hip preservation, and is more towards hip preservation in the sense of replacement, but not other type of surgeries. So again, you can have radiating pain to the back and to the knee, and the C sign which I spoke about, which patients will come. Next is looking at the range of motion. Usually, most of the times, you should have equivocal or similar range of motion on both sides. But depending on pathology, it can change. So every range, so whatever I have shown in this, it's not like it has to be that much. It is all a range of plus 10 on either sides, depending on the person. So the flexion range, the extension range, the rotations, internal, external, in flexion, in supine, in pronation, and then the abduction and adduction range should be checked. Usually they should be balanced on either side. So now, depending if in supination, if at all your internal rotation is more, it can be either because of anteversion. If it is less, it can be because of some kind of FAI pathology or retroversion. Similarly, in supination, if your external rotation is more, usually it is more because of retroversion. And if it is less, it is because of anteversion. Though there can be other causes of impingement, this is just a general idea of if at all you see these, where your brain should be going. Similarly, in prone position, if your internal rotation is limited, again, it can be increased in anteversion, reduced in retroversion, and also can be limited by soft tissue structures. Similarly, your ER in prone, again, limited by bone, that is your greater trochanter to the ischium, and crushing of soft tissues in between them. It can increase in retroversion and decrease in anteversion. So usually the normal finding, the hips should be balanced on either side. So once you have gone to the range of motion and you see there are certain tests. So the first test which I do, and I kind of combine it with the anterior impingement test, is the DIRI impingement test. So basically, you flex the hip to 90 degrees, then you start abducting and internally externally rotating, and you internal rotate more as much as possible that the hip allows. So usually with abduction and internal rotation, if the patient complains of groin pain, this shows there is issue with anterior congruence, or there is anterior FAI that might be causing pain. Once you do that at the same sitting, I adduct and internal rotate, which is the anterior impingement test, which I will show you later. The second test in the same hip 90 degrees, similarly in abduction, now from internal to you start external rotating the hip. Once you start external rotating the hip in this 90-degree flexion, because of the position of the hip, this, if at all the patient gets groin pain or buttock pain, this gives us that there may be a superior or posterior impingement or an anterior inferior instability. And the other is you take the child or the individual in the lateral position. In the lateral position, as you can see in the image, you put your hand over the posterior hip, a part of the hip joint, support the leg, and gently abduct. And in abduction, go from flexion to extension. When you go from flexion to extension, if the patient gets pain over the gluteal region, this shows that there is impingement of the lateral rim, that is the posterior superior part. And again, it can give an inference of a possible anterior inferior stability. And in the same situation, when you put force on the hip with abduction and start extending the hip, if the patient complains of more pain, that is the apprehension. That kind of confirms our anterior inferior instability. So the next test is the anterior impingement test, which is the most common test which everyone speaks about. You flex the hip to 90 degrees, take it in adduction and start internally rotating. Once you start internally rotating in adduction, the anterior part of the head starts of the femoral head and neck starts hitting the anterior rim of the acetabulum, and any pain during this gives us a positive anterior impingement test, and that tells us that there could be a CAM FAI or other type of FAI, or it could just be a provocation of the labral tear. If there is a labral tear, that as soon as the neck hits the labrum, it causes irritation and pain. So the correlation with labral lesion is quite good of this test. So a positive predictive value of almost 100% if you have a labral lesion while doing this test, and a negative test is around 13%. So the next is the posterior impingement test. So here you take the patient at the edge of the table, you extend the hip, and in extension, you start externally rotating and internally rotating the hip. So start with internal and then gradually start taking to external rotation. So when you start doing external rotation and in extension, one, it can tell us about anterior instability because we are forcing the hip in extension. So if the patient gets anterior pain, it tells us that there may be a possible anterior instability. And the second is if they get posterior pain, that is because when you're externally rotating, the ischial tuberosity and the femur are coming together. That it's not the lesser trochanter, it's the greater trochanter. Sorry about that on the PPT. So when it's greater trochanter starts coming towards the lesser trochanter, when it starts hitting the ischial tuberosity, and you can get pain, and that is the extra articular impingement, and this causes limited external rotation in many patients, and because of squeezing of the muscles in between these two bony structures, they can get pain. Then whenever you get just groin pain in deep flexion, so deep flexion can be because there could be excessive hip valgus which brings the lesser trochanter more forward, or if there is a prominence of the anterior inferior iliac spine. So when you go in deep flexion, the anterior inferior iliac spine starts hitting the femoral neck, and that can cause pain. Or if you have any increased anterior coverage, that means your anterior wall is more, that can also give you positivity in this test. So basically all of these tests can just kind of tell us in what region the pain is there. These are not very accurate in telling you this, if this test is positive this child has this. It does not work like that. You have to take everything into consideration. So here if you look, so you can see coxa valga. As soon as you start flexing, the neck and the trochanteric region starts coming towards the hip, and when there is a prominent anterior inferior iliac spine, that starts hitting, and that causes impingement, and that impingement is known as subspinous impingement. The next is the Faber test, which we do very commonly even while examining the back. Flexion, abduction, external rotation. Again, this test is similar to what we were discussing right now. A positive test can also give you when you have SI joint symptoms or when there is a greater trochanter and ischial tuberosity impingement. The next is a similar test again for ischiofemoral impingement, but it is done again in the lateral position. It is the same. You put your finger on the posterior joint line, holding the leg, and in the same, you start abducting and rotating, abducting and external rotating, so that the greater trochanter hits on the ischial tuberosity and you can get pain. So similarly, if you do that with full hip in extension, they will get severe pain and apprehension. So these are different tests for the same thing. The next is looking at some of the other soft tissues. So you need to look other than the range, there should be no contractures. So the Thomas test, which everyone knows, is to see for your flexion contractures if there are any. The prone rectus test or the Duncan, your Ellis test is to see if there is any rectus contractures. Then you look for the piriformis. So sciatic nerve symptoms, low back pain, and hip pain can also be present because of piriformis syndrome, which is because of uh, increased tightness of the piriformis muscle and the piriformis tunnel. So to check for the piriformis, make the person sit, legs hanging over the chair or your examination bed. Put your hand over the ischial just near the ischial tuberosity. Then you extend the knee, start adducting and internal rotating. So once you start doing that, you may either feel some tightness at the posterior part, or the patient will start feeling pain near the buttock. And a similar other test is taking them in a lateral position. Again, like the image shows, put your hand over the posterior joint, abduct and external rotate the hip, and tell the patient to do that against resistance, and they will get pain behind in the gluteal region. So that denotes that there could be a possible piriformis tightness in these patients. The straight leg raising test, which you would do for low back pain, for us, it helps in telling us if there is any symptoms of the psoas tendon. So it can be reduced if there is psoas tendinitis or any pathology in the psoas muscle. Then also we need to check for the power and strength of the abductors. It is extremely important for most of our surgeries that the abductor strength is good, because a bad or poor abductor strength affects the lever arm of the hip and can also increase the pressures over the hip. So always check for the gluteus medius and the abductor strength. This is usually done with the patient in the lateral position. Make sure in the lateral position the patients don't flex the hip. So a lot of the people have a tendency to start flexing the hip and then lifting the leg. So if you do that, that is not the abductors, that is actually testing the flexors. So make sure the hip is either neutral or slight extension, so that negates your flexors, and then tell them to abduct with knee in flexion and with knee in extension. So if you do it with knee in flexion, you will be testing the gluteus medius fibers. If you do it with knee in extension, it will be the entire gluteal complex. And the other part also to look at is for contractures of the iliotibial band. So if your patient is coming with symptoms of like snapping or pain over the greater trochanter, always look for contractures on the iliotibial band. This is also similarly done in the lateral position with the hip in slide extension and the knee in flexion. And then you leave the leg. If it stays in that position, that means there is a contracture. And similarly, with more flexion, you can test for gluteus medius. And from extension, trying to flex the full hip will let you know about gluteus maximus contractures if they are there. So I know it is a lot. So this is a table which kind of, it's like almost like a 21 step examination if you really want to go into details of every test that we have gone through a little bit right now. And the other table kind of tells us that what test gives us what kind of inference and what type of impingement does it test for. So I know it's a lot, and you may not do all of these tests in routine practice, but I would say at least doing the flexion adduction internal rotation test, the DRI, the dexrit, and the posterior test at least should be done, because basically with these tests you pretty much cover your anterior, posterior, and superior regions for impingement and instability. There are certain additional tests for snapping, for trochanteric bursitis, which can do. But from these, I would say two important tests. One is the bicycle test. The bicycle test actually combines most of the tests that we did before for your abductors and the gluteals by just making the patient in the lateral position and doing a bicycle motion. And the other thing is the adductor squeeze test. So once the patient is in supine position, you tell them to flex the hip and the knees, put a cushion or keep your hands in between on the medial surface of the knee, and tell them to push it inwards. Any pain on the medial side of the groin usually signifies adductor strain or any issues or pathology in the adductor muscle. This is the only test which you can check the adductor muscles. So you should always add that. So this was when I had visited Burn. This is the chart which they used to give us, that whenever a patient comes in clinic, this is at least the basic things that you should see. So first, like we discussed, in the gait and posture, look at the limb length discrepancy, Trendelenburg sign. Look at the abductor mechanism for the abductor gait, into, out toe. Look at the patella and look at the mechanical axis. Once you see that, look for the C sign, test the muscles, palpate the greater trochanter, look for the adductor pain like we were talking about right now. Check the pain and movement in sitting and cross leg. Range of motion, as we discussed. Then the provocative test, your anterior, posterior, flexion, and Faber. These are at least the basic provocation tests that you should be doing. The additional examination of the abductor strength, the adductor, the psoas, the rectus, and the Thomas test. And then last, always add for ligamentous hyperlaxity. So usually in women or girls, they have capsular laxity, which can be there especially in their pubertal age group, and they come very frequently with groin pain, which may resolve later once their capsule laxity reduces. Capsule laxity again is more in especially girls or individuals who are gymnasts, dancers, ballet dancers, and things like that. So you need to keep that in mind when you're doing all of these tests as well. Uh, Thank you so much. I know it was a lot. If there are any questions regarding the examination. Hello?
Hi, Avi.
Yeah.
Yeah, that was very exhaustive, Avi, and very
Yeah.
detailed. So I think hopefully these guys have taken down some checklist of things, but
Yeah.
I thought I heard either Saili or Nandini wanting to ask. So first let
Yeah.
them ask,
Please.
then.
Yeah.
So could you go through the adductor squeeze test once again, please?
Yes. So for the adductor squeeze, your patient is in supine position, hip flexed to almost 90, knee flexed. Okay. Tell them to keep it in abduction around 20-30 degrees. Your hands are then on the inner surface of the knee, and you're telling the patient with against your resistance to bring both the hips inwards. So when they do that against your resistance, they will get medial groin pain. So when they do that against resistance and get pain, that says there is an adductor pathology.
Thank you, sir.
Yeah.
So the dairy
The
and
D
dextrite,
DIRI. Yes, ma'am.
DIRI and
Yes.
dextrite.
Yes.
Do you recommend that they should do in all adolescents on an average who come with hip pain, or
Yes.
specifically when you're
Yes, ma'am, because the DIRI and the Drexit is almost a precursor to the impingement test. It's basically
okay?
starting off like that. So normally what I do is I combine both. I don't do it separately because you're anyways in that position. So I start with taking the hip in flexion, internally and externally rotating, taking it in abduction, internally, externally rotating, and then bringing in adduction and internally and externally rotating. So while you do that, you kind of end up combining three tests in the
Hmm.
same sitting, and any pain in internal, external, or in abduction, adduction, then you kind of know where the pathology is. Is it anterior or is it superior and posterior?
So all means otherwise no previous history of a hip pathology. Like
Yes.
there is a previous SCFE, previous Coxavara, previous sequelae. Perthes, all that. If it's there, definitely then we are expecting some malformation, and
Yes.
these
Ma'am,
tests
but
will be positive. But the ones who are just those school going, very high functioning these days, this class, that class, tennis B, AB, OB, those kind of children also, would you do it
so,
or?
ma'am, I would do it on all because, see, ma'am, if they have come to you, that means they have come with hip pain. Now,
Hmm,
our job is to find out, do they have hip pain? Otherwise, they are not coming to us for anything.
hmm,
So,
hmm,
if they are having hip pain, now our job is to find out which layer is the pain coming from.
hmm,
So based on this test, we will at least get an idea of, is it is it
hmm.
really bony or soft tissue? We will get some kind of an idea
Yeah, yeah.
before we move on to any radiological test. Because radiological test may still say there is a cam, but
Hmm.
clinically, if the test is negative, we are not going to bother to even treat them.
Do too much about it. Yeah.
Yes.
So I definitely like the layer concept a lot.
Yeah. So that way is it makes it very clear in your head
Yeah.
as to where it is, and then you can plan per layer as to what you really need to address.
Hmm.
Sir, I wanted to ask, so if these clinical tests are positive, for example, if there is anterior impingement positive, do
Yes.
we get any specialized X-rays or is it the same
No, so
PBH?
X-rays are the same. So the X-rays is a standard AP and frog lateral, and preferably AP in standing, because that's
Okay,
the
sir.
position where the hip is going to load. Because in supination, your pelvis can tilt and it can again change the mechanics. So preferred is standing, but if you can't get standing, supine is fine. So X-rays is the starting point always. Based on x-rays, now again you are not coming down to what is your pathology based on your clinical findings. Next would be an MRI, but an MRI also you will not be asking for a standard MRI. A standard MRI will not pick up certain things in the head, so you have to ask for certain radial sequences of the femur, head and neck. Otherwise, a lot of the FAI part can get missed. Only the capsule, soft tissue, labrum may get reported properly.
Sandeep, any comments, anything?
No, no comments. I think, shall we go to the X-ray so that, then we can, correlate those clinical findings with the X-ray
Yes.
Sure.
and,
Yes, so I'll
see
just go
what
on to the
condition.
radiology. Yeah.
Yeah, yeah, yeah.
All right. Okay. Yeah. Okay. Thank you. So again, so like the question was there, imaging in hip preservation again. So we need to know what we can easily reproduce. Otherwise, you can get whatever imaging you want. You're not going to get the answers. We want to see the proximal femur properly. We want to know about the femoral torsion, because torsion plays a very, very important role with all of the things that we are discussing. And we want to see the structures of the acetabulum and around the acetabulum. So now the workup has three things. The X-rays are your gold standard starting point. Majority of the things can be picked up in X-rays if a bony changes are there. The next would be your MRI that adds the cartilage, the labrum, and localizing other features of the acetabulum and FAI. The CT scan in the third stage, it mainly helps for planning of certain bony lesions if you are going for surgery, but only for bony lesions, and mainly for torsional profile, the relationship of your proximal femur with your acetabulum. So this is how the imaging matrix goes. We usually do not get all the scans done on every single patient. It is based on what you really want. So you add it to what we were discussing before. But radiographs are the first line of imaging. So again, if you don't know what you're looking for, you will never see it. So what people say normal is a myth. There's nothing normal. Everything is, it can be normal for you, maybe abnormal for me. So there are a lot of morphological variations which are normal for you. It may be abnormal for the second person. So we need to really see these, but just because we see them, that doesn't mean it is a problem. So we need to really understand them. So starting, as I said, is always with the X-rays. Majority of the times, most of the X-rays we get are not proper views, and hence you cannot comment on, I would say, more than 80% of the things if the view is not proper. So AP good view preferred is standing, but supine is fine. But in most situations, specifically in our kind of scenario, supine has more control and is more reproducible because you can teach it more easily to the technician. So in supine, but you need to be careful. Lot of people have the tendency to tilt their pelvis anteriorly when they are standing, which can accentuate the version. So you have to be very careful when you're interpreting these x-rays. Again, with standing, there are tendencies of people, they put their back behind and they have a tendency to posteriorly tilt their pelvis and can mask version. So again, be careful, especially when you're looking for version on the x-ray, be it supine or standing. So studies which correlate acetabular version, we know that supine X-rays are good enough if you really get them proper with good control and reproducibility. So we know pelvic tilts changes every angle that we are going to be discussing later. So in standing or sleeping, if there is anterior or posterior tilt, it changes our interpretation because X-rays are two-dimensional images. But if we'll take a three-dimensional image as well, it is not easy for our brain and our mind to correlate these things with the tilts and the versions like that. So they are not so easy. So now look at this X-ray. It's an X-ray of the same person in supine and the same person in standing. So you can see in the same person, you can have completely different views. So in the supine X-ray, if you just show this to someone, you will say there is crossover sign and there is retroversion and so forth. But the same X-ray in standing, you will say, oh, there is excessive, there is a reduced antiversion, there is maybe increased posterior wall sign and things like that. So think pelvic tilt and changes can change our entire interpretation. So always try and get good AP views. Teach your technicians wherever you're going to be doing this first. Add false profile, cross table, and frog lateral. I usually don't get all three. Frog lateral is good enough because most people do not do a cross table lateral or false profile properly. But if you can add a false profile view properly, that is good. It tells you about anterior coverage and lot of other things. So the ideal radiograph should have no rotation, no tilt. The SC, the sacral joint to the sacrum distance should be around 2 to 3 centimeters in males and 2 to 6 in females. It should be all in one line. Means if you draw a line through the sacrum, it should go through the pubic symphysis. That shows you there is no rotation. Both your obturator foramen should be looking equal. Your iliac crest should be on the same level. It should be a well-centered beam. Centering of the beam and the tube distance also affects the X-rays very greatly. So if you see this, the same X-ray, if the beam is closer and if the beam is far away, it completely changes the version that we will see. So always be careful and make sure that your beam distance is always same. Usually 80 centimeters is what everyone uses by standard. And again, centering of the beam. If your centering of the beam is higher or lower, again, it changes all the parameters. The centering of the beam should be at the level of the basically at the SC joint, at the same level of the acetabulum. That is where the centering of the beam should be there. So that, as I shown, this changes the rotation in the same X-ray in different views. You can get everything different. So rotation, your anterior wall, your posterior wall gets changed. Your crossover sign, posterior wall sign, and ischial spine these things can be changed with any malrotation. But your centerage angle, your acetabular index, your extrusion index, and your protrusion line, this does not change with malrotation. So whatever X-ray you get, these four things you can comment on with certainty. But the other things Unless the X-ray rotation is not perfect, you should be wary in directly commenting. So again, as we said, the proper X-ray, no rotation, no tilt, no obliquity, all bony outline should be seen. So that your anterior superior iliac spine, your anterior inferior iliac spine, so that iliac crest, anterior superior, anterior iliac spine, your ischial tuberosity, your greater trochanter, your lesser trochanter. So the line which I'm drawing now is the anterior margin or the rim of the acetabulum. So how do you draw it? You look for the lateral edge of the acetabulum and you look for the teardrop. You'll see the line going from the lateral edge of the acetabulum towards the teardrop is your anterior acetabular margin. Similarly, if you trace the bony shadow from the ischial tuberosity towards the lateral part of the acetabulum, that tells you your posterior margin of the acetabulum. So this way, now you know how to draw the lines for the anterior margin and the posterior margin. And then based on these and their relationships, we will look at other parameters. The next is the iliopubic line and then the ilioischial line. So these two lines are extremely important because they help determine or tell us where our acetabulum is. So normally our acetabulum is lateral to both of these lines. If our acetabulum is crossing these lines and going medially, then we will talk about coxa profunda and protrusio acetabula. So you need to look at these lines as well. Then the teardrop, which I spoke about. The line which is coming now is known as the sourcil. So that is the most sclerotic part of the acetabulum, and that is the weight bearing zone. So that is extremely important for us because that tells us how much of the weight bearing zone is congruent with the femoral head. So as we say, it's a sourcil, so like the eye, so it is inverted smiley. The size of the sourcil is extremely important because in certain severe dysplasias the sourcil is extremely small. The rest of the acetabulum medial to that is non-weight bearing. So if at all you're looking for any surgeries for coverage, it is that sourcil which we look for to get on the femoral head and not the rest of the medial cartilage. So this is the relationship of the lines that we were discussing right now. Then next is you look at the soft tissues. So there are, whenever there is an effusion around the hip, if you have a good X-ray, lot of the times, like in the elbow, you can pick up the fat pads around the hip and you can pick up effusion. So if you look at the black arrow, if there is the black shadow over there, that is the obturator fat pad, and that can tell you if there is any swelling or when there is infections on the inner side, that fat pad can be enhanced. The blue area is the iliopsoas fat pad. Whenever there is iliopsoas tendinitis or if there is a collection, that fat pad can also be enhanced. And the white is the gluteal fat pad. The gluteal fat pad, normally it just lies flush over the labrum and the capsule. But if at all the gluteal fat pad is increased, again, it can show if there is any inflammation or swellings around the hip over there. So the ilioischial and the iliopubic lines, which we were discussing before, they help us about knowing about the acetabular depth. So as I said, normally the acetabulum will be lateral to these lines. If the acetabulum is cutting or on the ilioischial line, that is known as coxa profunda. That means the hip is a little bit deeper and there is a chance that the entire acetabulum is covering the head more than what it needs to. And that can give us one of the signs of FAI. It can be global or more anterior or posterior. So this is coxa profunda. So if you look at the different type of X-rays, from dysplasia where the hip is shallow to a normal hip to a deep hip where the acetabulum is cutting the line to protrusio where the acetabulum is now cutting even the iliopubic line, touching or crossing even the iliopubic line, and that is protrusio. So protusio is the deepest form of acetabulum that you can get. And in protusio, you will get a global type of FAI because the hip is completely deep inside and over covered on all sides. So acetabular, so this is what protusio which I was discussing when it is completely inside and touching the iliopubic line. So here, if you can see again, so this is your iliopubic and ilioischial. So it is completely crossing the ilioischial line and it is touching the iliopubic line. So that is protusio acetabular. Then we start looking at the coverage. So in coverage, the acetabular index is usually what we see in younger individuals. In these adolescents, what we look at is the tonus angle. So the tonus angle is basically you draw a line which connects the both the ends of the sclerotic line, that is the sourcil, which we were discussing below, and that angle with the horizontal line gives you what is known as the tonus angle or the sourcil angle. So the range is from 2 to 10 degrees. Anything between that is normal. So the sourcil angle and the inclination also tells us about the coverage. So as we know, when there is DDH or hip dysplasia, it is shallow. That means the angle is more than 13 and higher. That means it is dysplastic. Between 10 and 13, it may be a borderline. Around up to 12 can be normal. But if it is 0 or going negative, that means the hip is deep. So basically, we want our normal acetabular inclination to be almost horizontal or slightly upwards, but never downwards facing. Next is the lateral center edge angle. This tells us about the coverage, amount of coverage of the head by the acetabulum. So it is draw the best fit circle, center point of the head, perpendicular to that, and join a line from the edge of the acetabulum to that center. And that gives us the lateral center edge angle. So similarly, again, depending on from shallow hip to deep hip, it if the normal range is from 25 to 34 degrees, anything more means it is over coverage, anything less it is under coverage. So based on that, it gives us an idea of how much coverage we want. So the others is the Sharpie's angle, which we draw by joining both the teardrops. But this line sometimes can be drawn wrong because in dysplasia, the teardrop shape is not normal. So people can make mistakes. So sometimes you can use even the join the ischial tuberosities and then join the lateral edge of the acetabulum to the teardrop. So that angle with the line gives you the Sharpie's angle. And the normal is around, again, 33 to 38 degrees. Next, we need to look at joint space. So a lot of the conditions we see, if the hip is subluxed or if there is chondrolysis or some internal pathology, the joint space can be narrowed. So ideally, you should have joint space more than 2 millimeters in all the zones, lateral zone, central zone, and medial zone at least. If it is variable in zones, that means there may be some cartilage pathology or subluxation of the hip, which we need to look at. The anterior center edge angle is seen on the false profile view. The problem is it is not easy, and even in actually when we are doing corrections, it doesn't really help us much. So I don't really use it that often. But if you are getting a false profile view, you can draw the anterior CE angle, and it tells you the amount of anterior coverage that is present over the femoral head. So the next is, how do you determine coverage? We spoke about the line. Now you know where is the anterior wall, and now you know where is the posterior wall. So the anterior wall, if you look at the ball as your acetabulum, you divide it into three parts. So the anterior wall normally covers about a third of that circle. The posterior wall you can say if you draw the circle of your femur and draw the midpoint, it should come just up to halfway of the circle. It should not be more than half. It is just up to halfway of the circle. So that is where your posterior wall should be. So again, now if you look at this red color diagram, if you see the center of the head, okay, so if you divide that circle now into thirds, in between is where the normal should be. Anything less or above is pathological. Similarly with the posterior wall, as I said, near the center means about 50% is where is pretty much normal. Anything less or more is abnormal. So that ways, with this simple way, you can kind of get an idea of where the wall is and where your dysplasia is. Then again, crossover, if your both the walls are crossing over, that can say either there is a deficiency of the wall or there is retroversion. And other sign of retroversion is the posterior wall sign. That means, so imagine if your cup is antiverted like this. Okay. So now if it is antiverted more, then what happens? The posterior wall goes away from the center of the head. So that that means so if it is the version is retroverting, then the line goes away from the center of the head. So it gives us a sign of retroversion, and that is a posterior wall sign. And similarly, we can look at the retroversion index. So if you draw the crossover, most of us do not draw these indexes. They do not really help us. They're more for papers and things like that. But you can draw these indexes and all of that and changes in that. The other is the ischial spine sign, which is very, very easily seen. And it again is a soft sign of retroversion. See, having all of these tests does not, or signs in the X-ray does not mean there is retroversion. It means there is a higher chance of having retroversion. So the ideal acetabulum, 80% coverage, 20% anterior, 50% posterior, around 15 to 20 degrees of antiversion, nice concave sourcil, about 0 to 10 degrees sourcil. The roof, as I said, should not be flat or short. And we need, based on the image I discussed below, you need to know what your coverage is. Is it normal, under, over, or global? Next is how do you assess instability? So now instability, one of the most common things which we have always learned is the Shenton's line. Any break in the Shenton's line is a soft sign for instability. Second is hip subluxation. Every sublux hip always get an abduction view. If in abduction view, the hip nicely goes inside, this basically tells us that the subluxation is because of the acetabular deficiency. So that means if now when I'm in the abducted, you're putting the hip inside, and when I do my acetabular coverage, if I take that same X-ray and keep it like this, that means my hip will be stable. So that tells me if my hip is reducible, and by just doing acetabular coverage, it will work. The next is the fear index. So this is one of the newer indices we use for instability. So fear index, basically, it is the acetabular inclination to the relative physeal scar, or if the physis is present, then the physis. If the inclination between these is 15 degrees or anything more, is unstable. If it is negative, means you want it to be in a negative angle, then it is stable. So this is a very good index which tells us about hip instability by just looking at the inclination of the acetabulum and the physeal scar. So rest is, if you're looking at younger children, you look at your Hilgenriners and your Perkins line, your acetabular index. You look at the proximal femoral shape. You want to look at the head neck deformity. If there is coxa magna, coxa vara, breva, that means a short neck, or a caput valgum. So you want to look at all of these kind of pathologies. Then is your migration index of how much subluxation is there. and then your Shenton's and your Calvé's lines to again tell you if the hip is where it needs to be. Next is looking at now the femoral head and the asphericity. So the sagging rope sign, like you can see here, this is very, very commonly seen when in post-septic sequelae in Perthes where the head is misshapen. That is because of the shape of the head, there is overlap, and that overlap looks like a sagging rope. Another sign for micro instability is what we known as a cliff sign. So if you see the head is round and suddenly from here it becomes slight flat. Once you draw a circle, so ideally the head should be round here and then it should go into the neck, which suddenly becomes flat like that. That is a sign of micro instability and possible labral pathology. So this is known as cliff sign. Secondly, you can see cystic changes in the neck. If those are there, it is a soft sign known as herniation pits, which denote that the patient may have CAM. And because of the repeated hitting of the neck to the acetabulum, these herniation pits may be seen on the X-ray. And then for the CAM, so what you see over here is a physeal scar extension sign. Every physeal scar extension sign does not mean there is a CAM pathology. Physeal scar extension can be a normal morphological change, especially in males who are heavy built and into deep flexion sports. For them, it can be a normal morphological change. So always be wary of that. Next is looking at the offset. So the offset, we look at something which is known as the alpha angle. If you draw a circle, you draw the of the neck and you draw the line which as soon as where the sphericity of the head changes, you attach that to the center of the head and that gives you the alpha angle. So any alpha angle more than 50, it tells us there is a cam deformity. And also the offset should be at least uh, more than 5 millimeters is bare minimum. If the offset is less, then cam morphology is causing problems. So the ideal femur, as we said, should have proper physeal line. Okay. Then next is coming to the torsion. So now most of hip preservation surgeons are looking at torsion with quite a renewed effect because we feel there is a lot of play of just torsion with FAI and some of the symptoms. So if you just look at this chart, you see the green is your normal. But if you see the white outliers, you can see with increased femoral or decreased femoral or acetabular torsion, you can have FAI symptoms just because of torsion itself. So be very, very careful with your clinical examination as the patient may not have any other pathology other than just torsion, and torsion can cause problem in the long run. So it is not like just leave it alone. So be very, very wary of torsion. So next, as I said, you've seen whatever you wanted on X-ray, but we want more information regarding the other. So that is where MRI comes into play. So the MRI in the axial, the coronal T1 and T2 tells us about the bony and soft tissue problems. It can also talk. I normally do not get CTs if I'm getting an MRI. You can get torsional profile with the MRI scan as well. And then, as I said, we get different type of sequences which are known as radial sequences to see the FAI if we have. And then you can look at intraarticular lesions, you look at your coronal, your oblique axial and sagittal to look at your cartilage and your FAI assessment. And also you can look at your entire acetabulum. So just overviewing now the image, your X-ray gives you around 80% of your information about the bony pathology and soft tissues, shadows at least to a certain extent. Your MRI talks to us about your labrum, the cartilage, the sphericity of the cartilage and the head, and the torsion. And the CT scan can help us for certain bony images, 3D imaging, 3D animations to help us understand certain pathologies and torsion again. So again, the beauty lies in the eye of the beholder. So go through the steps. Learn to first read the x-rays very well. Even a badly done or a normal MRI given to you, if you do not know what to look for, you will not know what to look for it even in the MRI scan as well. Try to get good views, assess all of this properly, look for the normal and abnormal variants, and then correlate it clinically to what findings you got on your examination, and add wherever you need higher imaging. But that does not mean every case needs CT, MRI, and the entire gamut. Choose as per your requirement and what understanding that you want from the hip. Thank you.
Boys and girls,
I know it's a lot.
overdose.
So much overdose of the hip.
No, it was very, very, very detailed. I think a lot of things were completely new to me also. But I think what is very important, what they should really retain with themselves is, even a simple PBH. How it's so difficult to get a standard
Yeah,
one, and now
yeah.
they probably understand the importance when Alric
So
keeps on
I
telling
would
in the
I would tell
OPD
them,
that there are 15 things to see in this X-ray, and
yeah.
they are like staring at him blank. What the hell is he talking?
I would recommend just start taking the AP X-rays, and Vadia has enough patients on a daily basis. Just spend 5 to 10 minutes on each X-ray. It
Hmm.
can be of a normal hip as well. Just start identifying all of these structures, where the anterior wall is, posterior wall is, where are each structures. At least start ingraining in your mind what structures should be where. Once you start getting aware of the normal, then once you start seeing these pathological hips, then you can go in order and start identifying all of these things. But the more you see, then only you will know. Like if I show an X-ray, yeah, okay, there's dysplasia. But okay, fine. But how does it help you to plan? That is where you need to start seeing all of these things.
Very, very detailed, and I mean, lots of good stuff. But yeah, it's an exercise, so you will have
Yes.
to definitely work on it. That's what I would tell all of you.
Yeah.
Please clarify your doubts right away, and we'll invite Sandeep's comments as well.
Good, wonderful, So, problem I think with adolescent hip is, there is no single place,
Yes.
where you can get all the information. So for, clinical examination and X-ray findings, you just go back to these videos and, watch them again.
Yeah.
And, all the things you will find in one place. So
And
thanks a lot for that.
no, thank
Wonderful. I think, we should have you once back and, just, now this was, we have come up till the investigation. So, the broad principles of management.
yeah.
So I think we will have, one more, you know, Tuesday clinic sometime in the near future.
Yeah,
So we will
definitely.
just finalize a date for that. Okay. Anybody else of you has any questions? Avi, if you want to recommend any, monogram or anything, any book where you can
So,
get all
so
the
I
basic
have
information.
few books. If y'all want, I can share them. They're a little detailed, but they have everything. So these are books which were given to my mentor. They are hip preservation books. They are quite a lot, but they can at least go through the examination, the anatomy. There's a lot in that, even about radiology and everything there. I don't mind sharing these
Soft
books
Yeah,
with
copies?
sure,
everyone.
sure.
Yeah.
Soft copies.
Yes, of course. Soft copies.
Yes, soft copies is fine. Don't otherwise give it away.
No, no, they are PDF copies, ma'am.
Huh, huh.
I have it on Dropbox and everything. I can share the link. I don't
Yeah.
have
Yeah,
that.
sure. Share on the
Because
link
they
and
will need to
everything.
have a rerun through this if they are
Yeah,
ever
yeah.
addressing any
This
of
is
these
not
things.
a like 10-15 minutes. You have to like go through multiple times. Like for me also, like every time in clinic, you have to keep going through that in your mind, and then it becomes like a routine thing for you. Unless you don't follow it, you just forget all these things.
Yes, so the clinical performa was also very good. That is something they should take home.
I'll send it.
And the
That's not a
same
problem.
way, X-ray, at least basic 10 features.
Yeah.
Boys and girls, any questions?
I had just a question, sir. Sir, during the COVID era, we had lot of avian,
Yes.
steroid-induced avian. So
Yes.
did we see in young adults also this
Yes.
avian, sir, or is it just, and was the treatment similar like core
No,
decompression, or
so treatment for AVN in adolescent and young adults is uh quite similar. So your early stage again is your core decompression and things like that. And depending for focal defects, you can do cartilage transplants, oats, and things like that. But full on bad AVN finally goes for replacement. So it again depends in what stage you catch them. So AVN in general were quite high. I'm starting to see more AVN, not just because of that, because now our rheumatology and other colleagues who have been using these medications for long are kind of, because these patients come with hip problems, are sending them to us. Otherwise, they would not bother about it. But we do pick them up a lot nowadays.
Maybe the awareness has increased or whatever, because there was a time when the senior most rheumatologists in this city would tell us, I'm going to put you all out of work.
Yeah,
I will maintain
because
them so well that.
yeah, because they used to just inject every joint which had inflammation, and then they used to say till adulthood just pull them. But now
Hmm,
the patients are smarter. Even they are sending them when they come
hmm,
with joint pain to us. And I have a now quite a huge practice of rheumatology patients where we've done hip preservation, and some have ended up needing hip replacement in young age, like 14, 15, 16. But whatever it
yeah,
needs to give
that's
them
true.
a good life.
That I used to see those terribly ankylosed hips only with Dr. Dholakia
Yeah.
once upon a time.
Yeah. We still see them,
But what about the
surprising.
patients in you to say GI, etc.?
So I couldn't hear you.
Hip preservation has any role in GI?
Yes, GIA also
So
it
hip
does have.
preservation, you mean to say, has a role in GI?
Yes,
Okay.
even in rheumatological
What are
patients.
the procedures related to
So I
it?
get
GI.
So in GIA and rheumatoid and things like that, there is a big
Okay.
role because they are on steroids and higher medications. So the earlier you pick them up, we can treat them with either biologic agents or with simple procedures. So like I have quite a big where we do early we pick up AVN, where we can do guided your intralesional bisphosphonates or your simple core decompressions, and you can provide relief in the hip for quite some time. But similarly, those hips also need regular screening, like how we talk about screening in CP and other conditions. These JI hips and joints also should be yearly screened.
Okay. Yeah.
So good. Very
Okay.
enlightening.
Yeah.
Thank you. Thank you very much,
Thank you
Avi.
so much.
Good.
I'll share the link over with the books and things. Yeah.
Yeah. Wonderful.
Yeah.
Okay, good night, everyone.
Good
See you all
night. Thank you
tomorrow.
so much.
Thank you, sir.